Hello, and welcome to a very special podcast that is part of a series I am leading on diversity and inclusivity with CME Outfitters. Today's CMEOCast is entitled Call to Action, Healing Racial Disparities in Dermatological Health. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Jenna Lester. She's an assistant professor and the director of the Skin of Color program at UCSF. Dr. Lester, I'm honored to have you joining us today, and I'm really excited about the discussion that lies ahead.
Thanks so much for having me, Dr. Peak. I'm excited to be here.
Wonderful. Thank you so much. Let me begin by starting with our first learning objective today, which is to define the metrics and effects of healthcare disparities in dermatology. You know, we know that there is a 2 to 3-fold greater risk of mortality for patients of color with melanoma. Dr. Lester, what can you tell us about the disparities in outcomes for this kind of skin cancer?
Yeah, this is a very important issue. We know that there are higher rates of cutaneous melanoma in white people, but overall, the survival of non-white populations that develop melanoma is significantly lower. So 67% 5-year survival versus 92% for white patients. And Black patients have the highest rates of late stage melanoma. They're 3 times more likely to be diagnosed in later stages. And there's a longer duration from diagnosis to definitive surgical treatment, which also does not help when we're thinking about improving survival. This is an area that needs a lot more research. And so as we're doing that, we may see different numbers shake out. But I think paying attention to this initially and with a discussion like this today is quite important. We know that overall there are inequities in skin cancer care. And although skin cancer is often termed rare in patients of color and Black people specifically, this designation, I think, shifts the way that we counsel patients about it. So yes, skin cancers are more prevalent in white patients, especially ones mediated by UV light, but we still need to hold this conversation with our patients of color, especially because we know that skin cancers like acrolentiginous melanoma, which are particularly aggressive, are more common in Black populations. And as a result, they get this cancer and maybe are not aware that this is a possibility for them, and they hold off on seeing the doctor for longer. And that's possibly accounts for part of the disparities that we see in outcomes. We also know that melanoma is understudied and undertreated in the Hispanic population. Immigrants without citizenship or health insurance are 50% of the melanoma cases. And 26% of Hispanic patients receive a diagnosis of advanced stage melanoma at the time of diagnosis, as compared to 16% of white patients. So these are really important facts to hone in on as we figure out research directions and as we think about how we're counseling our patients on this condition.
You know, that's super interesting. The idea that has been so prevalent for so long that skin cancer is a white people's disease that may permeate within the patient population, but that may be also within the physician population as well. So can you talk about some of the metrics on how structural and interpersonal racism may be some of the root causes for inequities in melanoma diagnosis and treatment within our profession as well?
Yeah, so I think it's in my mind, it starts with education. And I'm sure that as many people as you ask would have different opinions on this. And I think they're all important because they all represent different areas where we can intervene and shift this. But I think you're right that there's a structural component to this. So if you're teaching a dermatology resident that skin cancer is less common in Black people, which is true, but you don't introduce that nuance and say, well, these types are more likely to be to present in patients of color, and it's more likely to happen in UV protected areas. You don't give them the tools to then see a patient and change their exam or change their counseling to fit that. So I think the healthcare providers' awareness about this is important, and that awareness transmits or is transferred to the patient as well in how we counsel. So that I think is directly proportional to patient awareness about this. And public health campaigns that are developed around this also reflect the knowledge of the healthcare workforce about this issue. There are unconscious biases that I think also play in, and perhaps they're mediated by lack of dermatologist diversity. But I think just in general, they again are linked to these structural issues that make it difficult for us to see all the possibilities for a person sitting in front of us. And rather than checking boxes for that person based on their various identities, we should be seeing them as a person who has the possibility to have any condition, and let's be thorough and think through all of those things. Social determinants of health are incredibly important in thinking about all health outcomes, and melanoma is not an exception. So access to a dermatologist is incredibly hard for a lot of people, even people who are privately insured. But for people who have no insurance or a public health insurance option, it's a lot harder. Socioeconomic status plays into that, and exposure to risk factors. So for example, if you're an undocumented agricultural worker in the Central Valley of California, where there aren't very many dermatologists, but you have an incredibly high exposure to UV, a risk being UV light, all of those things converging into one creates a risk situation where you may be more likely to come to the doctor with a later stage of disease. And we know, to be more specific, that insurance restricts access for innovative therapies for 40% of patients with melanoma. We know that 8.5% of people don't have insurance. And I think a really important fact to note is that 29.6% of dermatologists accept Medicaid. And that's very, very low. And I don't know the exact number of how many dermatologists accept insurance in general, but if you are a person who has Medicaid and that suggests a particular income level and also a particular access to resources, that's really hard, a really hard number if you're looking for a dermatologist who is able to take care of you. So, and this all has direct implications on your mortality rates and the delays that you experience when you're seeking care from a dermatologist.
That's an excellent point, that a lot of people assume that delays in seeking care are exclusively about patient delays and not wanting to seek care, as opposed to patient barriers and being able to navigate physicians and healthcare systems willing to accept them and the kinds of payment that they may or may not have. Exactly. And when actually you said the percentage of around 30% of dermatologists who accept Medicaid, I thought that was a high number. I have my own biases around what dermatologists will accept for insurance. And I would have assumed that most of them would only accept high paying private insurance. So, but this is all very stark for people who have very serious life-threatening illness and really need to get in to see the dermatologist. Yeah. So we've talked about one of the most jarring disparities in dermatology, melanoma. Let's briefly discuss some of the more common, more benign conditions like eczema. That's something I see in the office all the time. But it can also disproportionately impact the quality of life and health for people of color.
Yeah, so one example is, the common inflammatory things that we think about are atopic dermatitis or eczema, psoriasis, keloids that develop, spontaneously or after a procedure, hair loss, acne. And these are all conditions that, with varying rates, I see patients that have experienced delays in care or have had a bad experience with one provider or another. And a lot of that, again, comes back to education, certain, depending on what you saw in residency, depending on what you feel comfortable treating, you may or may not be able to offer someone the full range of the treatments that are available for a condition. And I always think of, hair loss, scarring alopecia, which some designate as epidemic in Black women, as having fairly limited treatment options. And there are many researchers in dermatology who are working to change that, but it lags behind some of the other inflammatory conditions, I would say, like psoriasis, where there is a comparable number of people affected, but you look at the research dollars and how they're allocated and which has more, and it's quite apparent why research and innovation in these areas lags behind. But focusing on psoriasis, for example, it's a condition that, we're learning more about how it may affect your overall health, but people think, well, it's just your skin, and it's disfiguring. It leads to social isolation, pain and discomfort. More and more, we're starting to see how this chronic inflammation has an impact on cardiac disease, so long-term issues as well. But I have seen that this is something that's difficult for people to diagnose in patients with dark skin. We consider psoriasis a clinical diagnosis, so a diagnosis we can make while in the exam room. And this is not always the case in patients with dark skin. And this has to do with how we're taught about to learn about psoriasis. It's classically appears as salmon pink patches with silvery scale, and that's not how it looks in dark skin. And similarly, the severity scoring that we use to decide how severe someone's psoriasis is often underscores it in patients with dark skin, because some of those some of those metrics or markers for severity were designed to reflect severity in light skin. So this has implications on how we are interpreting someone's experience of their disease. This has implications on who's included in clinical trials and who's not, if you need a certain severity level to be included. So it has widely reverberating implications.
Very important. So you don't have to have a life-threatening disease to have important impacts on your health related to your skin.
Exactly.
So we've talked about this really important problem of inequities in dermatology and how they can impact your life, your quality of health. And so now let's turn to our next learning objective, objective 2, which is to optimize early diagnosis and manage dermatological conditions for patients of color. Unlearning is one of the key words in healthcare disparities, how to unlearn and improve melanoma care and outcomes for other skin conditions in people of color. How can we do that?
So when I think of unlearning, I think of unlearning some of the ingrained beliefs or thoughts or practices that are probably true for some groups, but need to be changed and unlearned and nuanced for other groups. So, and I think this rings true for many areas of medicine, not just dermatology. We need to unlearn that women are smaller men in regards to various treatments that we give, or that kids are small adults. These are all frame shifts that we've had over the years in medicine and have led to changes in the way that we do research and the way that we counsel and treat patients. And I think similar themes exist in dermatology. And I think it starts with the awareness that the healthcare provider has of disparities in education and in assessing skin of color. So understanding these disparities and understanding that two people, a Black and a white person presenting with the same stage of disease, have a dramatically different survival rate, I think would allow someone to think, maybe there's something I should be doing differently in my practice, in my day-to-day, so that I can help shift those numbers. I think that's a place to start. We all have to recognize that we have biases, and minority patients are more likely to be asked about their insurance status. Black and Hispanic patients face longer delays in getting appointments, and that is across the board. There was a recent paper published in JAMA Internal Medicine that talked about how this is something that happens when Black patients and Hispanic patients call for an internal medicine or primary care appointment. So we also have to realize we need to extend this definition of healthcare provider to our front desk staff and recognize how everyone's biases may be playing into people getting an appointment or not. Understanding the differences not only in how lesions that are suspicious for melanoma may appear in patients of color, but knowing the different locations of the body that they might appear. So having your patient take their shoes off so you can take a look at the soles of their feet and looking at the palms of their hands and their nail beds. Telling patients who have, nail polish on, these gel manicures are so popular. I say the next time you get them taken off, take a look at your nails and make sure you don't see anything that's concerning. And if you do, come back to see me. We need to change the way we counsel about skin cancer to decentralize this idea of UV exposure being the only way that people get skin cancer, because that's not how it happens in people of color. And we need to, do more research to figure out what assessment guidelines are needed and whether frequent scans and biopsies help in this situation. And I think that innovation or that investigation is what's going to be central, because it's been so lacking in previous years. We don't really even know what our starting point should be. So I think that that's really important.
And one of the take-home messages I'm learning and hearing from you is the repeated theme of innovation in the area of dermatologic treatments and science for skin of color. That this is an area that has lagged far behind in innovation for skin of other people and in comparison to other chronic diseases. And so that's really, I think, an important take-home lesson. Let's talk a little bit more. You had started talking about biases and the disproportionate asking for things like insurance. And that certainly happened to me when I went into the hospital to have my children. As an aged woman, they asked if I was there with Medicaid and if I was wanting to have my tubes tied because perhaps I'd had too many children.
Oh, gosh.
And I was like, these are my first kids, and I'm lucky to get these out my old body, but the assumptions that people were making just because of the color of my skin.
Yeah.
So let's talk a bit about how structural racism feeds into the social determinants of health that are partly responsible for disparities in access to care. We've talked a bit about interpersonal racism. And what are some of the ways that we as healthcare providers can overcome these deep-rooted barriers to inequitable health?
Yeah, that's a really good question. And, I think there are lots of ideas about this. I don't claim to have the absolute answer, but I think it's a process that starts with recognizing these issues and accepting them and not feeling, not having, the stance of whataboutism. When you hear an uncomfortable truth, you try to explain it away and figure out how it could be wrong. I think the outcomes that we see make it clear that there is some differential treatment, and this has been proven over and over and over again. So I think accepting one's role in that and is the first step in figuring out how you can begin to address it. And I believe that most people become doctors because they want to have a positive impact on someone's life. So in keeping with that theme and that belief, I think recognizing all the ways you need to constantly improve your care is important in doing that. So I think there's lots that needs to be worked out within dermatology in terms of how we categorize people, and I don't really like that word, but how we think about patients that come to us. Are we classifying them based on their skin color or on their racial or ethnic identity? And I think it's important to ask a patient and to understand their racial or ethnic identity, because that's important for intercultural communication and cultural competence. But I think when it comes to risk for skin cancer, skin type or one skin color has more of an implications on that. So even within a group of people that identify as African American, someone with very light skin has a higher risk of getting a skin cancer than someone who also identifies as African American who has very dark skin. So all of these things, these nuances need to be addressed. I think shared decision-making is very important, and is part of patient-centered communication, which is something that people have done research on over and over, and racially concordant visits have more of these elements, and patients who are racial or ethnic minorities report more satisfaction, are more participatory in their care in these scenarios. And it's led the Institute of Medicine to say we need to increase diversity in our medical specialty, dermatology included, in order to have more of this. But I think figuring out what the elements of those appointments are so that everyone can engage in them is important too. We need to consider someone's social situation, because we know that social determinants of health are important in delivering care, not only good care, but care that the patient can actually carry out. So switching over to our psoriasis example for a second, if you have an unhoused patient who lives with very little privacy, asking them to use a cream that they're smearing all over their body every single day or twice a day is maybe not something that they're able to do. So it's always important to ask questions and invite the patient's input. This is that shared decision-making in order to come up with a treatment plan that's optimal for them, not optimal based on what the textbook tells us, but what that person will actually be able to carry out. We definitely need to reduce barriers in clinical care and treatment. Some people think that having these community and free clinics are an important way of doing that. We need to also temper how these may contribute to more discontinuity of care, and how certain people are sort of relegated to these settings rather than creating sustainable systems where all people can access care in a continuous way. And we need to think about the special needs of certain patient populations, patients within certain socio-demographic groups, and whether there are certain targeted interventions that they might require. And I think more inquiry and research on this is needed before we figure out exactly what the right answer is. And improving access to treatments is incredibly important. I would also add improving access to clinical trials. If we think about sort of an analogy with breast cancer, triple negative breast cancer is more common in Black women, but the rates of treatments for this and special immunotherapies to treat this particular type of breast cancer lags far behind. If we were to increase our melanoma patients who are from diverse backgrounds in these clinical trials, will we find something similar? I don't know, but I think all of these things are important in collapsing these disparities in outcomes.
So Dr. Lester, from the data, we know that representation amongst healthcare providers matters. You matter. In minimalizing racial disparities and providing the best possible care for patients. How can we improve diversity and have more Dr. Lesters among dermatologists?
Well, I think that is a process that's going to take a long time. I think it first starts with a true commitment, sort of at all costs, to get that to happen. It starts. And there is a diversity champions program within the American Academy of Dermatology, where experts in this area have even proposed starting programs in high school, introducing young people to the idea of dermatology. If you've never been to a dermatologist, how do you know that you might want to become one? People see firefighters all the time, or police officers, and so they've had a chance to think of themselves in that role. But if you are someone that's not accessing this care for whatever reason, because your family thinks it's a luxury, or because like your grandmother has a cream that they can put on that and it'll go away, you may not ever have early exposure to a dermatologist. So that's starting early is one way. I think we need to re-envision what an excellent dermatologist looks like. And I think that starts at the residency selection process. And there are many programs who are trying to implement holistic application review so that we are looking at all spheres and dimensions of a person rather than just checkboxing scores and saying, okay, you know, they have a 280 on their boards, when that test, the step 1 test, has not been proven to produce higher scores, have not been proven to produce better doctors. So I think we need to break out of these ideas that we have of what makes an excellent doctor, and re-envision this, because we know these sort of qualifications or checkboxes tend to disproportionately negatively impact applicants of color. So though I think, you know, working on increasing the pipeline is one thing. And then we also need to re-envision how we are labeling a qualified person in the pipeline, because I'm not one that believes the pipeline is the only issue.
Yes, absolutely. Thank you so much for that. So one question for many patients and even some healthcare providers is on the uncertain risks of sun exposure for people of color. Mm-hmm. How do you answer this?
So I think that, you know, and I have colleagues who are doing this work, but there are so many people who are in very high UV exposure areas, people of color, and there are not explosions of melanoma in those areas or skin cancer in those areas of the world. So while UV exposure for certain people, you know, as I said, the lighter your skin, regardless of your racial ethnic identity, the higher likelihood you have of developing a skin cancer. I think we need to understand better how UV exposure plays into development of skin cancer in patients with dark skin. I don't think we know that right now with 100% certainty, especially when we recognize that that people of color are more likely to get skin cancers in non-sun exposed areas. But I still think it's important to realize that regardless of your skin tone, you can experience a sunburn. And so for that reason, it's important to wear, to practice sun protective behaviors. So sunscreen, wearing hats, seeking shade, all of these things are important. I think healthcare providers need to be aware of this nuance in understanding, you know, exposure risk and likelihood of developing skin cancer so that they're appropriately counseling patients without fear mongering. I think that's very important too. Sometimes we unintentionally make patients more anxious about things that we don't really even know if they're at a higher risk for. And as I've been saying over and over and over again, we need more research in this area. We need more patients of color in this SEER database, which is the big cancer database, so that we're able to do large population studies to really figure out what patterns are existing. And then it's also important to realize that sunscreen and sun protection happens, it's something that we need to do for various reasons, not just skin cancer prevention. So a lot of my patients of color have uneven skin tone or dyspigmentation, and that's one way that dark skin manifests extensive sun damage over time. Melasma is a condition I see quite often that is mediated by UV exposure, is not skin cancer. We don't think it impacts one's overall health, but it's something that has a big psychosocial impact on patients. And so talking about sunscreen to prevent that is really important too. And we think that dermatosis papulosa nigra, or the little sort of bumps that particularly Black people get on their cheeks. Morgan Freeman has a very well-known case of that, although I think he's gotten them removed. We think that could be a manifestation of sun damage over years. So it's important to realize that there is risk to UV. That risk is different for different people. But even if skin cancer is not highly ranked among those risks, it's important to understand what other concerns your patients might have so that you can counsel them appropriately.
Thank you. Thank you. Thank you, Dr. Lester. how informative this session has really been. I appreciate your time and all of the wisdom that you have given us. So this brings us to our takeaway goals that each of us can play in implementing a program to help end dermatological disparities in the United States. So just to summarize, they are: number one, to improve awareness of racial disparities in melanoma outcomes. Melanoma is just not a disease of white people. We have to think about people of color. Number two, to recognize, address, and monitor healthcare biases in managing dermatological conditions in skin of color. Number three, integrate best practices to account for structural racism and barriers in the screening, diagnosis, and treatment of melanoma and other dermatological conditions in people of color. And then last, develop sustainable models to enhance dermatology access in medically underserved populations. So please join me here at CME Outfitters for our ongoing series and upcoming podcasts and activities with more action steps against health disparities, including an upcoming briefcase, which is a patient case study in dermatology. You can find out all about the upcoming live events and view previous ones here on the DNI Hub link at the link that's right here on your screen. In particular, two recent podcasts will examine diversity and inclusivity in two important areas: maternal health and chronic pain. We will be adding new content every month, and we really want to hear from you, our audience, on what you need so we can make an impact on these important issues. Please remember to collect your credit for this activity today by using the Apply for Credit button on your screen. And again, thank you so much, Dr. Lester, for your input today. Thank you for all of your work in this important issue. And thank you, our audience, for all of your work in providing equitable and holistic care to patients around the globe.